Next speaker we have Professor Ruchi Goel, and she is a director professor now. The Guru Nanak Eye Center you must have heard in Delhi, one of the large eye institute in the country with nearly 300 beds, I think. And she is the small incision cataract surgery books we have written. Myself and Dr. Ruchi are the author of that book, and I think it's out of print nowadays. We are trying that it comes out again. It's not available in the market really, and so you'll get soon the new version of the manual of small incisional cataract surgery, which has given the Dr. Ruchi has illustrated almost everything so clear cut that you can understand every word of the SICS. And a lot of people, without seeing our surgery, seeing our faces, have learned SICS from that book. And hopefully that book photocopies are available with people, but original books are coming. Now Ruchi Goel will be speaking on a topic which is again astigmatism. Like you have got a pre-existing astigmatism in a patient, and SIC is one method which can tackle it, that you can plan an incision, length, the site, and everything to correct largely the pre-existing astigmatism, which is you cannot do with the phaco. So you have to use toric or so many things, and it becomes costly, toric lenses and all that. But SICS largely can take care of the astigmatism if you patient have it. So Professor Ruchi Goel, please.
Yeah. So I think this is one of the topics, sir, which all of us regularly we have patients which have pre-existing astigmatism. Of course, with the incoming of Indian intraocular lenses, toric lenses being quite reasonable now, despite all that, there would be situations where you would still need to manage without them. So, astigmatism with just one diopters of the magnitude, you can actually alter it with placement of your incisions. But when the astigmatism goes beyond one diopters, then whatever kind of incision you make, it becomes really difficult to negate it. So this is a study which we carried in our center, and we have published it in IGO. And basically, what are the strategies to correct pre-existing astigmatism is on axis. When I say on axis, is you preoperatively you do the keratometry, whether you use a automated keratometer or you go for a corneal topography, and then you decide where exactly you're going to plan your incision. That is the when we talk of on axis, that means the center of your your external incision should match the axis of the pre-existing astigmatism, the steeper astigmatism. Now, there are other, of course, the limbal relaxing incisions which people have used, but the consistency of limbal relaxing incisions have not been very good, and that's why maybe it has not become very popular. Toric intraocular lenses, of course, they give very good consistent results, and in patients where you can afford or you can, the patients are willing to buy, toric intraocular lens is the treatment of choice for all these patients. This is the, of course, whatever I'm going to speak, this is what we did, and this is published in IGO, so you can read the details. So what we did was where we used a 6 millimeter incision for, astigmatism, which was 1 to 1.5 diopters, and 6.5 incision for up to 2 diopters, and beyond 2 diopters we used a 7 millimeter incision, because we were leaving these incisions unsutured. We did not go for incision size more than 7 millimeter, just for the sake of the integrity of the wound had to be kept in mind. So I'll just show you, these are the corneal topographs of some of the patients, and you can see here, this is the K2, that is the steeper meridian is 44.67 at 26 degrees. So you can see this is the corneal topograph, and since the astigmatism was about 1.25, so we did a 6 millimeter incision in this patient, and post surgery the incision dropped down and it became 0.34. So you can see I could reduce some amount of astigmatism, and this is actually our findings which we got after 12 weeks of surgery. The 6 millimeter we could reduce the astigmatism to almost 1 diopter. With 6.5 we could reduce just short of about 1.5 diopters, and with 7 millimeter the maximum that we could reduce was 2.5 diopters. So to claim that, as SICS surgeons, sometimes very tall claims that we can, reduce astigmatism of 3. So at least with this much incision, you cannot, if you have to increase your surgically induced astigmatism to more than 3 diopters, then you have to go for larger incisions. And there the problem is that if you make a unsutured tunnel of 7.5 millimeter, you may have post-operative complications, which we are all aware of. So you have to strike a balance between what you want to induce and what you can actually induce, the problem complication that can occur. So I'll just show you how we went about. So first of all, the most important thing is that this is the preoperative marking. Now what I mean by, see, when you give a block, what happens is the eye tends to rotate. So you must mark your 90 and 180 degree beforehand. If you don't have access to a bubble marker, a slit lamp marking is good enough. So you can just make the patient sit on a slit lamp, make the slit horizontal and mark your 90 and 180 degree. Remember, these markings tend to get smudged. So what we use is, we use either a GV paint or there is a marking pen, and sometimes we actually use a 26 gauge needle to scratch it a little on at the limbus. Some people also make use of pre-existing vessels to mark the 90 and 180 degree, because if your markings are missed, it becomes very difficult to do your subsequent steps. So this part is very important. And here I have shown a bubble marker where you place the bubble in the center of these mark. That means this is exactly horizontal, and there you mark it 90, 180, and you can also mark over here. Sorry, this is 180, this is 90 degree. So after that, so this is on table, this is the Mendes marker, and you mark your axis. Like in this patient, I think it was 167 degree, and you mark exactly the incision size. Now remember, here our target is to induce astigmatism. It is quite different from what you were seeing in the previous presentations. So if you want to induce astigmatism, what should you do? You have to go closer to the limbus, you have to make a shorter tunnel, and that means 1 millimeter scleral tunnel and 1 millimeter corneal tunnel, or maximum 1.5, not beyond that. Because if you make a very long width of tunnel, your surgically induced astigmatism goes down. So now we have to go in the reverse direction. So this is why, and what I have done is, I have left a, can you see this frill of conjunctiva over here? So when you are leaving large incisions unsutured, they need to be covered with something. And the most important part, when we realize that all our patients are going to be old, and most of them would be having an against the rule astigmatism. And when these patients are going to have an against the rule astigmatism, that means your incision is going to be temporal. So that is the area where it is going to be totally exposed. So if they are going to be totally exposed, you are going to predispose them to endophthalmitis. So I have to cover my incision with something. So what I did was, I kept this conjunctival frill over here, so that after the surgery, I could at least cover my wound with the conjunctiva. So that is a very important step again. Now, I think the lesson that we learned was that we should teach our residents to do a temporal SICS, because if they really want to negate this astigmatism, all your patients going to be with temporal SICS. Now you see the placement of this ACM. Normally, this is the 12 o'clock position. Normally the incision would be here, and your ACM is going to be here. Now your ACM positioning is changed. So if your incision is here, your ACM is positioned over here. So this is another change that you have to practice. And the incision, of course, there is nothing difficult, nothing unusual about it. The nucleus is prolapsed as is. Now people who are used to using superior rectus, they have a little trouble, because there is no superior rectus to help, because here you are doing a temporal SICS. So, but because the incision size is reasonably large, you are not going for 4.5 or 5 millimeter incisions. So otherwise, if you can make use of viscoelastic to deliver the nucleus, and this is of course the hydropressure which has been used, and this is the IOL placement as usual. What I started doing is another modification, which I'll show in my next subsequent presentations also, is that after doing this is what I was trying, this is securing the wound totally. So even if you have to enlarge your incision to maybe 7.5 and your tunnel is good, make sure that you cover it properly with the conjunctiva and keep a watch on the patient. That is one thing. So to reduce my post-operative PCO also, what I've started doing is most of us have phaco machine in the hospital, and we have your bimanual port. So what I do is I use the bimanual to do a polish, because with this method of aspiration, sometimes the polishing is left, and not only the even if you're using a PMMA square edge and your capsular is not properly polished, you end up with a posterior capsular opacification. Here, when you're trying to, it's a kind of a refractive surgery when you're trying to decrease the astigmatism. So you need to have a patient who does not even develop PCO. So you can do these minor modifications to improvise and improve your surgical results. So to conclude, the maximum astigmatism that we could correct with the 7 mm incision was 2.5 diopters. And another thing which we commonly read is that the surgically induced astigmatism is less in the temporal incisions, which of course, because of the greater horizontal length of the limbus, and factors like the blinking reflex of the lid is not there. It is known that temporal incisions cause lesser astigmatism, but in our series of patients we did not get statistically different results, which was again, before I did this study I had this premonition that superior is worse than the temporal in that respect, but then we had no difference in SIA. The integrity of the tunnel could be maintained, and the wound could be left unsutured stably till 7 mm if you have made a good incision. If your tunnel at any point of time, you have made irregular planes or something, then in those cases of course your surgically induced astigmatism can go higher. So again, people who claim that their SIA is larger, maybe because the wound integrity may not be that good. The other thing that can do, if you give too much of postoperative steroids, what happens is there is delayed wound healing. That can induce more astigmatism. And if your corneal length of incision becomes less, that also induces more astigmatism. But to create a stable wound, we chose to keep 1 mm on either side of the limbus, and a good plain incision and a covered tunnel. So thank you so much. That is all in this presentation.
Ruchi, you covered so well the subject of the astigmatism, and you can handle it if you know pre-existing and where to put the incision and all that. I just wish to ask you a question really, that the person sitting here, you left the frill of the conjunctiva near the limbus so that it can be sutured back. Still, it is a large disease.
So it's not suture, it was cauterized.
No, yes, it is co-opted with a cautery. But what I'm saying that these large incisions sometimes do open. So if you have to suture it, tell them that which kind of suture we generally do. We don't do the vertical suturing in these large incision, we do the horizontal suturing. So tell
Okay.
that suture which
So,
you do, figure of eight.
Sir, here the idea was to induce astigmatism. If I put a suture, I could
No,
not.
I understand that.
Yeah. So otherwise, we put a figure of 8 suture to seal the wounds which are larger in size. So if your integrity is not good and you are not able to, when you're hydrating, you feel that the chamber is somehow unstable. For the sake of safety, you must put a figure of 8 suture. But as I said, was an entirely different perspective where we were trying to. So if you put a suture, you cannot induce that astigmatism. That is all.
Just to say that the horizontal suture generally don't induce the astigmatism. That is the reason for that. That vertical sutures will produce the myopia on the vertical meridian, but horizontal sutures generally don't induce anything on the cornea. So figure of 8 means that you take from one, go this side, go this side. I think you can do it. Figure of 8, or we